Good morning and welcome to today's THA Governance Excellence webinar. My name is Adrienne Nordman and I am the Assistant Vice President of Member Relations and Education at THA. I am joined today by Karma Bass. She has over the past 25 years, Karma Bass has worked with healthcare leaders across the country on governance, strategic planning, philanthropy, policy, and board effectiveness. Prior to launching her consulting career, she served as president and CEO of Alliance Healthcare Foundation in San Diego, where she reported to an independent 11-member non-for-profit board. Notably, Karma spent 10 years at the Governance Institute, where she led its member services, research, and publications. Karma is board certified in healthcare management and holds a master's degree in public health with a focus in health services administration from San Diego State University. With that, I will turn it over to Karma.
Thank you so much, Adrienne. Good morning, everyone. It's good to be here with you today. Thank you for taking time out of your incredibly busy lives to be with me. I want to start off by just saying that my intention in being here with you today is to be of service and provide you with some ideas and tips and maybe some tools that will help you be even more effective in the role that you've chosen to serve in, whether it's a hospital health system executive, a volunteer board member, clinician who also interacts with the board. My intention is to provide you something useful, and I hope you will let me know as we go through. If you have any questions, there's a chat function, and I do have it pulled up on my second screen so I can see the chat, and Adrienne will let me know if I missed somebody's question. But I want to start off by mentioning that in being asked to talk about governance excellence, I gave some thought to what would be most useful to folks who wanted to hear more about this. And so let's see if I can make this go forward. The session objectives that we developed was to start off by giving a little bit of context. I'm not going to assume that everybody watching this webinar understands the healthcare industry and has a background in health administration or is a clinician in any sort. So I'm going to start off with a little bit of context setting because I think that's absolutely critical for everyone to be kind of on a level playing field. I am going to spend the better part of the session talking about board key roles, responsibilities, and authorities, and then I'm going to close out with 4 of the things that I tend to see when I see a board that is more highly performing, things that I tend to see being in place. I want to start off by letting you know that what I am sharing with you are my guidelines, and they are simply that. Governance is still far more an art than a science, and so I encourage you to take what I'm telling you and in fact what you read and what you may hear from others as guidelines and not gospel. You really do need to take it and try it on, see if it's working for your board. And at the end of the day, it's not about the structures you have in place or the policies or even the practices. It's about the way the people serving on the board come together in service of the mission that, in my experience, really makes a difference between a highly effective board and one that's just sort of meeting their basic obligations. So I'm going to start off by talking about the industry that we work in. Again, not assuming that everybody has a healthcare background, and I think, you know, I always find this information to put our healthcare industry in context. I find it really helpful for me. It's galvanizing at times, it's motivating, and it's also very interesting. And so for those of you that are board members and work in a lot of different contexts in your lives, and I know we have some of you on the webinar here today, I would encourage you to take this in. We are going to send the slides out afterwards, and you're welcome to take a look at it, take a look at the source information, and see if any of this resonates perhaps in other areas of your life or might be interesting to share with others, friends, family, loved ones, neighbors, that sort of thing. So this is the statistics that you have probably heard before, but I want to just ground us in this conversation that the United States spends more than any other nation on its healthcare delivery. And so what you have here in front of you is a collection of countries that are part of the OECD, which is the Organization for Economic Cooperation and Development. It's an international organization that's comprised of the world's wealthiest nations, and they come together to collect data and establish policy for economic well-being and the citizens' well-being. And so what they've got here today is one of the more recent surveys that they did, looking at how much each nation spends per capita on healthcare for their citizens. And what you see here is that we by far, and this isn't, I want to be clear, this is not a cherry-picked selection to show you, that make us look like we stand out. There aren't any countries between Germany and US in terms of how much they spend. What the dark blue bar is how much the government spends on healthcare, and then the or corporations spend, and then the green bar is how much an individual spends out of pocket, and this is a per capita annual kind of spending. So and this equals about 18%, a little bit more than 18% of our gross domestic product annually. Being someone who has worked in healthcare all my life, my father was a physician, my sister is a nurse, I happen to think it's not a bad thing to spend a good portion of our nation's wealth on the well-being and health of our citizens. So 18% in and of itself for me would not be a horrible thing, except for the fact that I also know that we're not getting the kinds of results that we should be getting for the amount of money we're spending in healthcare. So I want to share this with you, and this is really unfortunate that people in the United States experience the worst health outcomes overall of any high-income nation in the world. And what you see here are 4 different metrics to perhaps characterize the worst health outcomes: the infant mortality rate, children that die in their first year of life. Our rate is higher than the other countries, and it's higher than the average. The maternal mortality is particularly stark and problematic, and the part of this maternal mortality that's also very sobering is the fact that our high rate actually hides an even higher rate for women of color, particularly Black women, who suffer maternal mortality rates at a multiples level of what the white Americans experience. So this is a significant issue that we have as a nation. The percent of adults in the United States 18 and older who have multiple chronic conditions is 30%, and that is higher, as you can see, from the other countries, wealthy countries in the world. And then the percent of the total population that is obese, which we know leads to all sorts of health outcomes that are not optimal. So these are just a few things, and you can go on to the OECD website, and I encourage you to do so because it's just a treasure trove if you like data, and take a look for yourself. There are, in my review of it, there are 2 bright spots that we do better, and I believe it is breast cancer screening and detection. We do better than other countries in that, and our ability to access MRIs. So those were the 2 that I recall, and looking, kind of going, okay, well, does the United States, are we doing better in any respect? And there are a couple, of course, but the ones that I would say for myself, are most stark and give me a sense of a sobering reality for our healthcare delivery system not working optimally are these here. And then at the end of the day, the other kind of bottom line outcome is that our life expectancy is much lower than other OECD countries. And as you can see, we experienced a significant dip after 2020 because of the COVID-19 epidemic. The people of color lost significant years of life off their average life expectancy during COVID, and the white Americans did as well. So you can take a look here and see. And this is just not to bum you out or depress you, and certainly not to cast aspersions on the hardworking men and women that serve in our healthcare delivery system, because that, I don't believe, is the reason for this. In fact, it's not because we have too many doctors, and it's actually, we have, as you can see here, you could make the case that we have too few doctors. The average number of practicing physicians that we have per 1,000 population, 1,000 people population, is 2.6, and that is among the lowest practicing physicians per 1,000 population. Also, and these two are related, obviously, the number of consultations per person per year with a physician in all settings is also much lower than other wealthy nations in the world. Sweden, of course, is lower than us. New Zealand and Norway are lower than us, but we have an average of 4 visits with a doctor in any setting per person per year in the United States. And as you can see, some of the other nations have rates that are much higher than that. So it's not that we have too many doctors and they're doing the wrong thing. It's also not that we have too many hospital beds that are driving up costs and we're keeping people in the hospital too long, which is a narrative that sometimes gets discussed because there are incentives now in place for hospitals to get folks out of the hospital more quickly, and also for them to avoid people having to come back into the hospital. You may be hearing about this in your boardrooms, but many of the payment mechanisms now are paying hospitals by the diagnosis and not by the number of days that they say. So if somebody has a particular diagnosis at a particular level of severity, acuity of their care, and they stay in the hospital for 3 days, or they stay in the hospital for 5 days, the hospital gets the same amount of money. So there's an incentive for hospitals and clinicians to take care of those folks quickly and get them out the door as quickly as possible if they're being paid in that kind of mechanism. Of course, the clinicians are focused on what's right for the patients, and the hospitals are as well, but the payment mechanisms that are in place from the insurance companies, the federal and state governments, do drive practices, as we know. And so with regard to the hospitals, what we see is, again, compared to wealthy countries across the world, we actually have a very low, second to the lowest, average length of stay for inpatient care for our patients. And given what we've seen before, we know it's not because we've got healthier patients with the rates, unfortunately, that we have of chronic conditions and obesity, but our average length of stay in the United States for any type of inpatient care is 4.8. And as you can see here, most other nations are above that, and Korea has an average length of stay of 19.1 days. The other piece of information that I think is helpful, and this is probably useful in some of the policy dialogue we're having about hospitals, especially in rural areas that are at risk of closing, is that the number of total hospital beds per 1,000 population in the United States is quite low. So you might hear the term overbedded. And while there may be certain communities where they have more hospital beds than they need, and that there's a case to be made that that can drive up healthcare costs, across the board in general, we certainly are not overbedded as a nation. As you can see from the statistic, we have about 2.8 hospital beds per 1,000 population, and that's right in line with a handful of other wealthy nations across the world. So this is kind of a context that I wanted to give you in terms of how the United States compares to other wealthy nations. I want to go in a little bit more in my context setting, a little bit more narrowly, and talk about the financial snapshot of hospitals. And this information that I'm sharing with you comes from Kaufman Hall. They're an advisory firm that works with hospitals and health systems, and they provide excellent information. And they put out a monthly snapshot, a flash report, they call it. That's a pretty quick read, and if you like to understand what's going on in hospitals' financials across the nation, I would encourage you to sign up for it. It's a free service that they provide, and they work very closely with the American Hospital Association, so you'll often see their snapshots referenced on the AHA website as well. But basically, the key takeaways that we're facing is that this is an incredibly challenging time for hospitals in the United States financially right now, and this is across the board Some of the nation's largest health systems, a couple of whom are my clients, are struggling mightily, having incredible kinds of layoffs that haven't been seen in a very long time in order to get their costs under control. Revenues actually have gone up slightly in the last year for hospitals, but the costs have gone up even much more precipitously. And so hospitals are finding themselves in this very difficult position financially. They're also finding themselves in a difficult financial position because the CARES Act funding is going away, and it's very clear that there will be no more bolstering of hospital financials from the federal government or other sources to kind of, which was done during the course of the pandemic to help hospitals keep their doors open. And so what we're seeing here is very difficult times financially for hospitals. Many organizations are having to make very difficult decisions about laying off people, slimming down the administrative and the executive team, certainly, but also closing down service lines and laying off clinicians, nurses, and the like, because they simply cannot afford to support services that, while they may be incredibly important to the community, are not paying for themselves. And it's one of those kind of Sophie's choice that the hospitals find themselves in of, do we close down this service line that is very valuable to the community and people would miss it if it were gone, or do we run the risk that in 2 years we're going to have to close the hospital altogether? And that, ladies and gentlemen, is the wonderful position that you as board members walk into and are asked to be weighing in on and have conversations on, and also represent these very difficult conversations to the community at large. And this is a hard conversation that many hospital trustees are finding themselves in, to have to explain. One of the clients I'm working with right now is a 5-hospital health system, and they're closing down OB services, baby delivery services at one of their hospitals, and it is not being well received by the community, and the board members are being questioned as to why. They're being questioned by the obstetricians, being questioned by the nurses. They have a labor union there, so the labor union wants to know why. And it's been a very difficult conversation for them to navigate, but the bottom line for them in looking at all of the information that they have before them is that they simply cannot continue to offer that service in that location. In this case, that is an urban health system, so it isn't that the women with to deliver babies have no other options. They do, but it's going to be more of a drive for some of them, and it isn't the place that many would prefer to deliver. But those are the kinds of decisions that hospitals are being faced with these days. In terms of why this is happening, and I referenced this a little bit earlier, but when you ask a hospital executive these days what their top 3 challenges are, they'll say labor, labor, labor. It is all about the difficulty in finding nurses, clinicians, other kinds of folks as well. Hospitals find themselves in the difficult position of competing with retail and other types of organizations for the entry-level positions. And there's oftentimes, just like for us where we live, if you go into a restaurant, they'll have whole sections closed because they simply don't have the staff to service the restaurant. The hospital is no different. They have to close beds and close sections of the hospital because they don't have the staff to clean it. They don't have the staff to care for the patients if they put them there, that sort of thing. So that is the #1 challenge facing our hospitals. And you can see some of the others here. The recession, of course, does impact the hospital, although healthcare tends to be inverse to the state of the economy. We aren't immune from it, particularly those of you that are located in rural communities, and the rural communities being hit so hard. My experience in working in rural communities is that they're much more tightly knit, and so everyone's future is much more closely tied together, and the hospital, of course, is a part of that ecosystem and suffers along with the community when there are difficult challenges being faced. let's see, one thing I want to share with you here, just a couple more slides to set the stage, but this is just to give you an example, again, for those of you that are board members that are relatively new to healthcare. Welcome to the most highly regulated industry after nuclear energy. This schematic was done by the American Hospital Association. It is a number of years old, but I have to tell you, I don't think the regulation has gotten any less since then. So these are all the various agencies that put requirements on a hospital. And so sometimes in the boardroom, as you're hearing things be said or things that are being done, and you're thinking, well, you know, why in the world would you run your business that way? That makes no sense. Why don't you just do X? Well, the chances are good the reason they're choosing to run the business in the way they're running it is one of these boxes here, the high regulation of the industry. I was working with a hospital back east at one point in time, and the board chair there was a man who had been very successful, was very dedicated to the mission of the hospital, had been very successful running his own company. He sold appliances, and when the hospital was facing revenue challenges, he was like, well, let's just increase our prices. You know, we've got this this list of prices that's posted, let's just increase the prices. And so there was a conversation that was actually a very interesting and I think helpful conversation about the fact that, you know, the prices that are listed on the sheets that the hospitals have really in many cases have very little or no bearing whatsoever on what they actually get paid for the services they provide. So as a new board member coming in, I want to just kind of give you this context that if things that are done seem to make no sense from a business standpoint, you're probably right, but they make sense from a regulatory or a political or a reimbursement standpoint. And that's where kind of asking good questions comes into play. So what I see right now as I'm traveling the country and working with the men and women who work in hospitals and serve the nation as clinicians and as board members, the pressures that are facing individuals right now are staggering. I've been in this business almost 30 years now, and I've never seen anything like it. I mean, this is stating the obvious, but people just are not at their best right now. And the kinds of pressures that are being brought to bear after 3 years of an incredibly difficult time when people, everyone, whether it's a frontline caregiver or a health system executive, everyone is burned out. And so as board members, what I think you have the opportunity to do is to really bring a sense of calm and a sense of caring, because that is what's needed for the men and women that work in our hospitals and health systems. And it's caring for the people who care for the people who care for the patients. And that never is a bad idea in my experience. And I think it's needed now more than ever in terms of, you know, asking tough questions, of course, and staying clear on what the purpose of the organization and staying true to the mission, but also approaching this work with an increased level of emotional intelligence, if you'll forgive me using an overused term, but that idea that the people really do need to come first at times. And the crisis that we're seeing in this country in terms of the mental health crisis, that's everywhere. And we need every single one of our caregivers and our executives and our board members to be able to show up in their best selves and take the time they need to take care of themselves. And so I really encourage you as a board member to do what you can to show that kind of caring. And the role of a board, I think a lot of times is that sort of titular, you know, kind of serving as the face of the organization to some degree. And the kind of energy and heart that you put forward is very well received in my experience in watching boards that kind of take that approach. So I want to switch over and talk more about what the board roles and responsibilities are. And I'm going to go over some of the sort of fundamentals because I'm not assuming that everybody watching this has been a board member for decades. And even if you have, I have heard from some that have, you know, when I was first starting in this field in my 20s, and I think I met with a woman who was, I think she was in her 90s, and she said, young lady, she was in Texas, I've been on this board for 30 years and that was really helpful. So, and I think she'd been on the board at that point longer than I had been alive. So even if you've been on the board for decades, I think it always bears some reflecting on kind of what are we here to do and what is this about? And at the core of it, and fundamentally and most importantly, the purpose of the board is to focus on the mission. And that actually is the gift that you get in serving on a board, is that you have the opportunity to show up and really constantly be bringing people back to the reason we're here. And it can be such a gratifying experience. I recall working with a CEO at one point in time, and I was asking him, this was when I was at the Governance Institute, and I did a lot of interviews with CEOs, and I was asking him, you know, what do you find most helpful about having a board? Because of course, a lot of CEOs, if you talk to them privately, will have a lot of complaints about having a board, and some of them are legitimate. I have been in that role myself, and it is not easy if you have never done it to work for a board. But this particular CEO, and asking him, you know, what do you find most helpful? He said, you know, it's the one place I go every month where we consistently talk about not just what happened yesterday or last month or last year, but what's going to happen next year and 5 years from now and 10 years from now. So I really encourage you as a board member. There are a lot of details that you will be asked to review, and there's a lot of information that you will need to know and that you will be presented information about. To the degree you can constantly be in your mind and in your questions and in your reflections, bringing things back to the mission, that really is one of the core things you do. And it may seem to some, because I know there's a lot of type A, hard charging individuals who decide to do community service by serving on a board, and that sometimes doesn't feel as kind of tangible as some would like, but it really is the core of the purpose of a board. So you know, some people will have the mission on the wall in the boardroom. I think that's a terrific idea. Some people have it at the top of every board agenda. Anything that you can do that's a constant reminder and reflection on that, I think is a great way to start any conversation. So the purpose of the board in essence, and I love this quote, this is an incredibly old book, but I think it really is kind of, it encapsulates the challenge that you have as a board member, is that you are both deeply concerned about what's going on in the organization, the future of the organization, the effectiveness of the organization at serving its purpose, its clients, its patients, but you are also not in the organization. You're not, most often board members are not paid, and so you have this sort of separation. And that challenge is that you're both part of the organization and you're not part of the organization. And you are the one who can, in some ways, ask the questions that folks down 24/7, you know, 7 days a week are looking at the same issues. You can kind of be a little bit above and ask the question that folks may be overlooking. It's that, you know, can you see the forest for the trees? And sometimes we in healthcare, we do tend to get a little bit myopic, and we do tend to focus on things to the point where an outside perspective and a simple question can be incredibly powerful in reframing the dialogue and considering options that maybe we haven't considered before. Because healthcare is in many ways stuck in its ways, and we are going to need to transform healthcare in this country. It is fundamentally broken by just about any metric that you look at it. And again, this is not to cast aspersion on the men and women that work in the front lines, that see the patients. I am so grateful for the nurses and the doctors and the caregivers and the executives that are willing to show up every day and still care for people with such high quality care and with such heart, despite the fact that they're working in a construct and an environment that's so challenging. So the board members have this opportunity to sort of stand above and think about what folks are kind of the big picture of what's the mission, why are we here, but also have information about what's really going on, and trying to help executive teams and the clinicians all in partnership navigate is one of the key roles that a board can play. There are 3 legally mandated fiduciary duties that are written into the state corporations code in most states that I'm aware of. I think some states have just 2 written into their corporations code, but these are the legally mandated. When you hear the term fiduciary duties, this is typically what's being referenced. And most of the hospitals in the United States, I think about 80 to 85%, are not-for-profit organizations or governmental organizations. It's only about 10 or 11% that are for-profit corporations, but they are corporations nonetheless. And these fiduciary duties are ones that the boards of directors are typically expected to adhere to. And with the complexity of the healthcare system these days, with about 2/3 of the hospitals in the United States are now part of health systems. And so if you are one of those majority of hospitals that are part of a health system, you may find yourself on a board that has certain duties that it's responsible for, and then another board, either a system board, maybe perhaps above your hospital board in the system, or if you're at the system board, you've got hospital boards at the local locations. These boards tend to divvy up responsibilities in terms of what they take care of, what they oversee. But as a general rule, it's never a bad idea for board members to be adhering to these fiduciary duties. And so I say that because I've been in working in health systems where there's kind of these ongoing arguments about whether something is a fiduciary board or not. And it's a very complicated conversation, as you would imagine, but essentially you're never going to go wrong if you adhere to these fiduciary duties. And that means that if you're going to make a decision about something really big, you've taken the time to ask good questions, and you've taken the time in advance to review the material that was sent to you. This is why reviewing board packets before you come to the meeting is so absolutely critical. And I just was at a retreat earlier this week where I was reminding the board members that they needed to set aside time the week before the board meeting to review their packets, because it had come up in their board self-assessment that they didn't think they were all reading their board packets in advance. So that is part of that fiduciary duty of care, that you've taken the time to be knowledgeable. And if you're not getting your board packets a week in advance, that's something to start asking questions about with your executives and your board liaison, the support team, because you do need that information in advance, and it's not unreasonable. It's a hard thing to do. I don't want to sugarcoat it. It's not an easy thing for the executive team to do, and they're never going to necessarily be perfect at it. There's always going to be last minute information, but you should be getting a good substantial proportion of the information for the board meeting a week in advance, and you should be reading it. The duty of obedience means you know what's in your articles of incorporation, you know what's in your bylaws, you know what's in your board policies, and you've taken time to review them and make sure that you're following them. And then the duty of loyalty is probably where the most kind of heat and light is in healthcare right now, because this is the fiduciary duty upon which the whole conversation about conflict of interest is predicated. So the duty of loyalty means that when a decision is made, it is made on behalf of and in the interest of the corporate entity as a whole, period. So if you are, for instance, a chief of staff who's been elected by the physicians who practice at the hospital to represent them, and you have a voting seat on the board, the difficult position a chief of staff may find him or herself in is that the medical staff physicians expect you to represent them and carry water for their issues, which certainly sitting at the board table, it is appropriate to share the point of view of the medical staff physicians and to make sure that the board and administration understands what the practicing physicians care about and what concerns them. But at the end of the day, when it comes time to take a vote on an issue, even if you're the chief of staff elected by the medical staff, you have a fiduciary duty to make the decision that's in the best interest of the hospital, period, nothing else. And this is also where you find things where folks may be asked to step out of the room for certain conversations or not participate in certain votes because there is what's deemed to be a conflict of interest. And these kinds of things are very important. These are not high bars to get over by any stretch, but they're very important to keep in mind and be mindful of, because this is where not-for-profit boards can be tripped up. And there's not a lot of, it doesn't happen very frequently, but when it does, it's pretty significant and it's completely avoidable in my experience. So I think it's important to keep this in mind. So as a board member, it's important to remember that you have no individual authority. The only time the board actually exists is when you're gathered together in a duly called meeting of the board. So this is very different from any other role you may play in your life. It means that you as an individual can't actually opine as a board member unless it's something that the board has taken action on. And you as a board collectively need to, if there's issues that are before you, you need to have enough time as a group to deliberate, to decide, to come up with a common point of view so that you're giving a single set of directions to your leadership and information to the community. And it's that speak with one voice. The other thing that's important to note, and I really do, for those of you in smaller communities and those of you that are newer to the board, this is a hard one because it flies in the face of kind of what the community might expect or what you might have experienced in other capacities that you've had in your professional life. But really the only one that should be getting direction from the board is the CEO. Everyone else in the organization who is an employee of the organization reports to someone who reports to someone who reports to that president and CEO or administrator, whatever the top person in your organization, whatever their title is. And it's very essential, important that you as a board respect the hierarchy of authority that exists in the hospital and not be perceived to be giving direction to anyone else in the organization other than the CEO, because since you sit essentially at the top of that hierarchy, you're undermining your own structure if you were to be perceived by others in the organization as someone that they could go to get around the CEO. And there's if we had more time, I could tell you lots of unfortunate stories about where that's been the case and the difficult things that have happened as a result of that. But I imagine you can imagine them yourself. So as a board member, you're going to have a lot of information that you're going to have access to, and it's appropriate and you should, but I think it's very important to remember up front that these information are confidential and cannot be shared beyond the boardroom itself. And if you ever have a question about whether something is confidential or not, the first thing I would do is say, assume that it is confidential. So if somebody asks you, hey, how'd the board meeting go? What'd you guys talk about? I would say, you would tell them, oh, it was a great meeting and we talked about some really important issues and in the hospital's doing some really interesting things. And then tell them something that's already been released in a press release or is already on the hospital's website or is already well known in the community. Be very careful that you are not the one sharing confidential information of something that's transpired in the boardroom. And again, this is particularly challenging for physicians who practice in the hospital and also serve on the board, because the other physicians know that they serve on the board and they want to know what's going on. But it can be very damaging to the organization if information that's discussed in boardroom gets out, and individuals who have triggered those circumstances often did so completely unknowingly and unintentionally. So just a reminder for that. And some boards do have public meetings. So there's, you may be on a board where your meetings are subject to an open meetings law. And if that's the case, then even then I would suggest to you, just as a best practice, to let people, if it's an open meeting and they want to know what's happening, encourage them to come to the meeting themselves. Encourage them to come and see try to avoid being the mouthpiece of what happened at the board, regardless of kind of whether the meeting was open or not. And on that vein of what's confidential, I want to share with you just a bit about HIPAA and let board members know the Health Insurance Portability and Accountability Act. Of course, we've all heard this because when we go to the pharmacy, we now have to stand behind a sign. This was passed in 1997. It actually was a landmark law that was enabling a lot of the electronic health records that we now have ubiquitously everywhere. This actually got some of the initial kind of establishment of the regulations to allow those were passed in HIPAA. But what we know HIPAA for is the provisions that it has to do with privacy. And as board members, what you need to be aware of is that you are considered a HIPAA covered entity. So the federal government, if it is investigating violations of health privacy, it can include what board members knew and might have shared. And so as board members, you may get access to lots of people's personal health information, and you probably get it not because you sit on the board, because it's actually not that common for personal health information to come into a boardroom, although sometimes it does. But you may get somebody may tell you about their stay in the hospital, and they may want to tell you lots of details about it, and they are welcome to tell you whatever they want, of course, particularly as it relates to their own health care. But you have an obligation not to repeat that to anybody else. And the reason that I share that with you is that even if you didn't get that information from the hospital, if you are known to have shared somebody's information about somebody's health condition or health care, and that person wants to take issue with the fact that their health information or their health care information was shared, they could file a claim, and they could claim that you got that because of your role as a board member, and that could put the organization in some legal jeopardy. The violations for HIPAA, and they happen regularly. The fines for HIPAA violations start at $50,000, and they have gone into the millions of dollars. So be wary about that, and understand, as it says here, you're not able to gossip about what's going on for people's health care any longer. As a board member, it's probably not a great practice. So conflicts of interest, I mentioned that a little bit earlier, and I just want to be clear in saying that a conflict of interest doesn't mean the person is a bad or less than desirable board member, and it definitely has nothing to do with whether that person is capable of setting aside their personal interests and making decisions on behalf of this other entity, the hospital. It actually is a matter of law, and so I've had conversations with board members where they've felt in my bringing this topic up that I was somehow impugning their ability to be either ethical or to be focused on the interests of the hospital. And in fact, that was, of course, not my intention. It's that the lawyers are going to come in and say, based on the things that you do for business or the things that your wife does for business, those potentially have some overlap with the interests or the business of the hospital whose board you serve on. And so therefore, in these particular areas, you are not considered to be a disinterested board member. You are not considered to be free from conflict. And so therefore, we're going to ask you not to participate in conversations or not to participate in votes that have to do with these topics. I've worked with board members who were executives of local ambulance companies, and they made great board members because they had a very good understanding of that side of healthcare for the community. But that person, of course, was not able to participate in conversations when it came up to talk about contracts with ambulance companies. So that's just a small example. And these can be managed very easily. Most organizations do this, and I would recommend it to you. If you haven't filled out an annual conflicts of interest disclosure, then that would be something to ask about, because that's a great practice that you can just put in place and it protects the organization. So One of the questions I often get asked by new board members when we start talking about conflicts of interest and HIPAA and legal liability and fiduciary duties, does this create exposure for you as an individual? Here you are volunteering your time and your expertise in this incredibly challenging healthcare environment for this very important organization, and is this going to put you at personal liability? And what I am here to tell you is that rarely, if ever, has happened, and there are a number of reasons why you personally should sleep very well at night, and also you collectively as a board should sleep well at night, so long as you're doing these things here. And what I would say to you is that the decisions you make don't have to be perfect decisions, and you may find, unfortunately, that some decisions the board makes in hindsight could turn out to be not the best decision. That does not mean that you are liable for having done something wrong. As long as it is clear that the board made the decision in good faith, with the information that was available at the time, the people that had conflicts of interest on that particular issue were not involved in the conversation, they were not involved in the decision, and the board had been given good information, and they believed that it was in the best interest of the hospital when they made the decision, then that decision, even if in hindsight it turns out not to have been the best decision, is not a violation of any kind of law, regulation, policy, etc. The main thing is that you want to be able to say all of these things with the check marks are true. And that's why many organizations pay attention to the board packets being distributed in advance, keeping track, having a corporate record of what was distributed in advance, what was shared in the board meeting. The minutes are a good record of kind of the topics that were discussed and any decisions that were made. And the board clearly, from all of its documentation and from folks who were there at the time, was clearly focused on trying to do the right thing for the organization, for the patients, and for the community. If those things are in place, there's very little chance of you even being asked about this, and at the end of the day, you wouldn't be held liable for it. The other thing that you also can take assurance in is that every organization that I've ever worked with, I think it's just part of the standard insurance packet, they have something called directors and officers liability insurance. So if somebody did bring a lawsuit, because of course people can sue you for things that make no sense whatsoever, but if somebody wanted to bring a lawsuit claiming that the board had done something or board members had done something on behalf of the organization that was not appropriate, there is this directors and officers liability insurance that would be triggered by that event, and the coverage on the insurance would then cover the cost of legal defense and all that sort of thing. So you, in serving on a board, especially if you are serving on an unpaid board, have lots of protections in place that make this not personally risky for you in that sense. So as we talk about the role of the board, one of the hardest things I think for board members is this idea of wearing so many different hats. And the best boards and board members that I've worked with practice a real kind of discipline about clarifying what hat they're wearing in any point in time and being clear on whose interests they are focused on taking care of as the priority. Now, granted, I want to hope and I truly believe that in most cases the interests of the hospital are aligned with the interest of the doctors and the interests of the nurses and the interests of the patient and the interests of the community, because that is, after all, the mission of the organization. But for many, because there are so many different hats we wear, again, particularly in rural America, small communities, I love working with small communities because there is such a dedication, and because people's lives are so, people are so close-knit in those communities, you find yourself wearing many of these different hats. And it's important to kind of be aware of which role you're playing at any given point in time. And the best way to make sure that this is happening also is to just be explicit about it, have a conversation about it. If you're entering into somewhat thorny issue, there's service lines that have to be that you're contemplating if they have to close them or shut, things have to be moved around. It never hurts to start off the conversation by saying, okay, we're going to have this conversation here, and I just want to remind everyone that this is going to be a hard conversation for many of us because we do have so many different people that are expecting things of us. And as we sit here today, our role as a board member of this hospital is really to focus on what's going to serve the hospital best so that the hospital can continue to serve its mission for decades into the future. And that's really what this is about. And unfortunately, for many organizations, that's what it's about. It is sort of an existential conversation, because if you don't make the difficult decisions that are in front of you that have to be made, remember that in itself is a decision. And far too often, in my experience, I've seen hospital boards equivocate and ask for more information and ask for more meetings and want more discussions, because it's not that it's not clear what a decision needs to be made, it's just that it's such a hard decision to make. And so as a hospital board, keep in mind that your job is to make decisions, even if they're difficult ones. How are we doing? Everybody still with me? I hope this is helpful. I'm looking over there, I see no questions, so feel free to chime in if a question comes up for you. So the role of the board, as you can see here, and I want to kind of walk through the role of the board, the CEO, and the medical staff, because those are sort of the three locuses of power in a hospital. And the role of the board is to sit at the top of the organization, to be that sort of lighthouse, to look far off into the distance and set the strategic direction in partnership with the executives. The CEO, your only direct report and your only employee, does myriad things, as you can see from this list, and also many, many other things as well. And the boards that I've worked with, the best boards and the CEO, share a very close relationship and are in constant communication. The CEO and the board chair in particular is a really important relationship. And so having an appreciation of each other's roles is one of the ways that boards can be particularly effective, in my experience. The medical staff is, for hospitals, it is required by the Joint Commission or whatever accrediting body that you have. It is required that you have this organized medical staff, which is comprised of all of the physicians who are allowed to practice medicine in your hospital. And so medical staff term includes both physicians who are employed by your organization and work at the hospital, and it may also include physicians who aren't employed by the hospital but come to the hospital to see patients there. And they have a particular role to play, obviously, and the chief of staff is the elected physician who represents their interests, usually in interactions with administration and with the board, and they have these particular roles, of course, to play in caring for the patients. The board chair is a very important role on the board, although the individual, him or herself, does not have any special authority. So the best board chairs that I've worked with really are facilitators first and foremost, and they're focused on developing and maintaining good relationships with the CEO, having that sort of close professional relationship where the CEO can use the board chair as a sounding board, and the board chair will have the CEO's back and support him or her on these thorny issues that invariably come up. The board chair will facilitate a great meeting. I think that's the most obvious sign of a great board member. And typically, what you see with board chairs is that they're not the first ones to speak at the meeting. I think when you sit in that role, carrying, having that gavel in your hand, whether you literally have a gavel or it's just figuratively, your voice carries a heavier weight. And so I would encourage you, if you're in that role, and you probably do this anyways, but make sure that the others in the room are speaking, and your job is to draw folks out, because if we only needed one point of view, there would be no need to have a board. And so trying to foster that kind of conversation in the room that is respectful and collegial, but also definitely not groupthink. You want diversity of perspective, and so the board chair has an opportunity to draw that out from folks and play that role. One of the things, as I work with CEOs and boards, one of the things that is sort of the perennial gift to consultants like me is that there is often conflict between CEOs and boards. And so I'll get called in because the CEO will say, "You've got to come fix my board. They're driving me crazy." And oftentimes these are the things that I hear from the CEO about what's driving them crazy about their board, is that they're over involved in operations, of course. That I hear that all the time. There's a cop mentality that the CEO can't partner with the board because he or she feels like the board is playing gotcha with them, waiting for him or her to do something wrong so they can catch them. Leaking confidential information, someone who doesn't take time to really understand this very complicated industry that we're working in, and yet walks into the boardroom sort of pontificating wisdom as if they should be, immediately acted upon without any additional conversation. Those kinds of things are what I hear from the CEOs that I'm working with when there's some kind of rub or conflict with the board. And conversely, the boards get frustrated by executives who want to bring them just fully baked cakes and say, "Okay, here it is. You haven't heard about this before, and it's a huge portion of our business, and this is a huge business deal for our organization, but we've done all the research and we've decided this is the right thing to do, and so we're going to present it to you. You didn't get anything in advance. We're presenting it to you at the meeting, and we'd like a motion to approve it." And the board finds themselves in a very difficult position because they want to support the CEO and the executive leadership, who clearly have done quite a bit of work on this issue, but this is the first the board is hearing of it. And it's very hard as a board to feel that you're doing your job and not just being asked to rubber stamp things if you're not getting information in advance, or if you're not having an opportunity to discuss the really big deals over multiple meetings. So that's something that boards do get frustrated by. Being expected to serve, having meetings that are weekly and hours, the amount of time that individual board members end up being asked to dedicate to these is really significant. And for some people, if they feel like their time is not being well used because they're not getting material in advance, and the meeting topics aren't really clear as to what's being asked, that's when they will get frustrated by those excessive time expectations. This idea that the board just sits there and listens to report after report after report is an incredible frustration for many boards, because they didn't join the board because they wanted to sit there and be, PowerPointed to death. They really joined the board because they thought they would have an opportunity to be a part of it and give their input and be in dialogue with the leaders of the healthcare organization. And so if that is the expectation that people come to the board service for, then it's not unrealistic that they would be frustrated by meetings where there's maybe 5 or 10 minutes out of 2 or 3 hours that people actually have a chance to talk and ask questions. So that you can read the rest of them, but these are some of the things that I see. And the reason I share these with you is not just for entertainment value, which maybe it is, maybe it isn't, but also because I think the more we can put ourselves in the shoes of the persons we're working with, the better off the relationship will be. Because at the end of the day, healthcare is always about relationships. I was watching a presentation at the American Hospital Association Rural Healthcare Conference also earlier this week, and one person there was talking about healthcare is love. Healthcare is about love, and I would say yes, and healthcare is about relationships, and that is true whether it's at the bedside or whether it's in the boardroom. And so for people to have good relationships with each other, it's important that there be some appreciation for the shoes that that person is walking in. And if you as a board member are able to put yourself in the role of the CEO that you're working with, then perhaps it will make it a little bit less crazy making when he or she does something that you don't find easy to deal with. So just kind of that thought of understanding where the other person's coming from. Conflict at board meetings, I just want to be clear. One of the things, there's sort of two extremes. It's like a Goldilocks thing, right? Some boards, they just go along to get along. There's never any differences of opinion perspective expressed, and you never hear that anyone around the room really has any kind of divergent thoughts from each other, and that I think is not a good thing. I told a board one time, I think you guys are too nice. I think you never really ask challenging questions, and I think that that's important to do. On the other hand, oftentimes the boards I work with, there's just rife conflict, and it is so negative in the way that you see here that it's paralyzing, and it really does undermine the board's effectiveness, certainly, and it can get in the way of the organization's effectiveness. I've seen that happen as well. So I want to be clear that it's important to disagree and find a way to disagree without being completely disagreeable, because otherwise, what's the point of having a board? So especially in these days when you're going to make really difficult decisions about things that are going to make people external to you in the boardroom probably rather unhappy. And I'm sorry about that, because it's a hard time to be in healthcare. And I know those that serve on the board come to it because you want to give back and you want to be of service, and you're being put into a situation where you're going to have to make very difficult decisions about things where there are really no good answers and no necessarily good solutions, and that will be a hard thing to do. But I also I'm heartened by this, because I think the men and women that serve on the boards and the executives and the clinical leaders that I work with, this is really the time we need great leadership. If the seas are smooth, there's no need for leadership. There's no need for great leadership. And right now the seas are definitely not smooth. So now is the time for folks that are thoughtful and willing to wade into these issues to take them on. So the distinction between governance and management is really kind of a perennial issue for boards, and it's a journey. There's never, in my experience, really a destination. You never arrive at it, and then you are done and you're good and you can kind of go on happily ever after. This is something that each board defines somewhat for itself, but involvement in operations is not the purview of the board typically. And in fact, it's that sort of looking forward through the great big windshield of the future rather than looking behind you in the tiny little rear view mirror of the past. That is what the board should be focused on. Asking good questions is the job of the board. And so that's what I would suggest to you, kind of as you go through this. Some of the best boards that I've worked with are very clear on when they're practicing governance and when the management team is doing its job. And one of the ways to know this is by to have a conversation about it. I loved when I'm in a board meeting, there was one quality committee meeting that I was in, and a board member who had an experience before he retired of selling medical devices, but he wasn't a clinician, but he was a great quality committee leader. And they were having this conversation, and it was very interesting. And he said, I think this is a fascinating conversation, but I just want to ask the question, how does this relate to the board's role? And is there some way we can kind of bring it back to that? And so asking a question like that from time to time is a wonderful way to just check in about whether your board is doing a good job of navigating that distinction between governance and management. So I want to leave you with just some of my ideas about, in my experience of working with boards now for going on 30 years, what do I see the highly effective boards doing differently? And there are 4 things essentially that, as I think about kind of what makes a great board different from a good board, there's a couple of things that I have experienced. And, you know, this is not an easy time to be on a board. My grandfather served on the board of our small community hospital for 25 years and was the board chair for a number of those years. And back in that day, you know, this was the 60s and the 70s, and the role of a board member really was, you know, there was the 3 T's. You were expected to give your time, you were expected to give a little bit of your treasure and write a check every year when it came time for the annual hospital gala, and you were expected to give a little bit of your talent. So whatever it was that you did professionally, if you were a lawyer or an accountant, you were kind of looking over the shoulder of the executives and kind of making sure that they had any kind of advice and counsel in that particular area that they needed: time, treasure, talent. That was kind of what was asked of you. Nowadays, it's very different. And so what I would suggest to you kind of as a kind of a baseline for going into this role is get comfortable with being uncomfortable. This was a quote I heard from a chief financial officer who I think is brilliant when she was talking to the board about some difficult financial situations they were dealing with, and that there really was no good answer. So get comfortable being uncomfortable. Absolutely put a stop to infighting. There are times when I come into organizations and the kind of turf wars that are going on are so unproductive, and to my mind as an outsider are so petty that it really does not serve the organization, and it doesn't represent the individuals involved well either. So if there's any of that going on, please, you know, find a way to be a force of calming the waters, and let's set that aside. We have to question our assumptions in healthcare. We will not get to where we need to go by following the rules that got us here. And for boards, what's your metrics? What does success look like in terms of data that you should be looking at? And this is not an easy answer, by the way. So don't expect that, you know, the management team is going to know exactly what you're asking for and be able to bring you a dashboard tomorrow. It's going to be something you're going to work over time, but figure out what success looks like and identify some metrics and move forward with that. Recruiting for different types of board members than you've had in the past. This is a huge issue, and I'm not touching on board diversity here, but I have a real strong passion for it, and I would encourage you to, the way that you've always done recruitment of new board members, please reconsider it. If you haven't taken a different look at how you're recruiting board members, now's the time to do it. We've done a lot of writing for the American Hospital Association. They have a lot of great resources on their website. So please take a look at that and reconsider how you're recruiting people to the board, because you need people that are going to be the board of the future of the organization, which is very different than the organization that it was 5, 10, 20 years ago. So number one, what I see is boards that are really outstanding focus on the role of the board itself. They really understand that they're there to govern, and while they bring expertise as executives in all sorts of different areas, when they show up, they are students of governance, and that is what they pay attention to. The other thing that is very important, and I mentioned this earlier, is that strong board-CEO relationship, understanding what the board's roles are, having conversations with the CEO about it, having agreements and formal board policies, and making sure that you're giving the CEO regular, consistent feedback, at least on an annual basis, about how you, the board, feel he or she is doing in his or her role, and also in the relationship with you. It's very important for there to be that sort of ongoing dialogue. These are just some quotes from some folks that I've worked with over the years that I really appreciate, and just kind of a little bit tongue-in-cheek, because we love our acronyms in healthcare, don't we? So nose in, fingers out, you know, follow that approach. And then good enough, press on. You're never going to know everything there is to know about a topic as a board. And if you wait until you do before you decide, you will have missed your window. So I think, you know, this understanding that you could always get more data on something, and healthcare organizations have, you know, endless rabbit holes of data. But at some point, you need to understand that you've got enough information to make an informed decision, and then you move forward from there. Let's see. The third thing that's most critical is making sure you're having effective board meetings. This is the currency of the board. It's the only time that you exist as a board is when you're gathered together in meetings. So making sure those meetings are the best ones you go to all month or every 2 months is really critical. You see some suggestions here for making that happen. And then last but not least, certainly, is this idea of a healthy board culture. There's a lot of discussion right now in healthcare about the culture of the workplace and the culture of the organization. And you've heard the saying, I'm sure, culture starts at the top. So the way that you all in the boardroom interact with each other, the way that you treat each other is absolutely critical. And it needs to be set in such a way that it sets a tone and the expectation and an example for the rest of the organization. So this is what I would encourage you to focus on as you go forward in your role. It's not just about having the right committees or the right policies or the best bylaws. It's about how are you working together as a team, and are you spending time making sure that you're cultivating the kind of culture that you want for everybody that works in the organization. So I'll leave you with this quote from Jeffrey Sonnenfeld of What Makes Great Boards Great. It's a great article from the Harvard Business Review, again, written a few years ago, but I think it's really still very, very salient. The idea that boards need to be strong, high-functioning work groups first and foremost. And so hopefully what we've talked about today has given you some ideas for that. And hopefully there's something in here that has resonated and maybe will give you some tricks to try or tools to use. I think that if there's anything that I've mentioned during the course of the session that you are wondering about or would like me to say more about, I would welcome questions in the chat. I also have my contact information here and would welcome follow-up emails. So I'll just kind of take a little pause here, see if anybody have questions, comments, anything I can elaborate on.
Karma, this is Adrienne. I am not seeing any questions so far, but thank you so much for this very robust conversation and discussion.
It's my pleasure, really. And I want to just, again, thank the individuals who are with us and thank you for what you do in serving your communities. This is really hard stuff as board members to wade into. I know it's hard as an adult who has a deep area of expertise in one particular area to step into a completely new field and agree to serve on a board where you may know very little to nothing about healthcare. It's an intimidating experience. The acronyms and the buzzwords don't help, but it's very important, worthwhile work, and I just want to encourage everybody to become students of it. You can learn this. It is a fascinating area to spend time, and I have seen boards make a huge difference in how the hospitals and health systems are able to serve their communities. So I do know that what you do matters, and I know it makes a difference. And right now we need every bit of leader and contributor that we can right now in healthcare. So thanks to everyone out there. I think, well, I'm Adrienne, should we give people back a bit of their day?
Yes, that sounds good. Thank you again. Really appreciate you being here.
Yeah, thanks so much. Thank you, everyone. Good to see you.